Dear students, hope you all are fine. So, this is the second video lecture of the topic anti-malarial drugs. It is my request to all of you that you go through the first lecture in detail, right? Because otherwise, you will not be able to understand or memorize the classification of anti-malarial drugs, as well as that lecture will also help you in understanding the basic details of pharmacology of each of this class. Fine. So, yes, today we'll start first with the symptoms of the malaria. Last lecture we have understood the life cycle of the malaria, where we have tried to understand some of the symptoms of the malaria, right? But today we are going to get you can say all details, right? So, definitely headache, fever, fatigueness, muscular pain, back pain, chills, right? This we have correlated with the hemolysis that occurs because of the, you can say that, rupture of RBC, right? When the merozoites get released from the erythrocytes, when the all hemoglobin has been consumed, right? Is been acquisited, right? So that chills, shivering effect could be because of that. High grade fever, right? Either quartan or tertian fever, right? That depends on the uh, duration of the endoerythrocytic cycle, right? So this will be characteristic on the basis of different types of species. Some species you will have fever every third day. Some species you will have fever every, or you can say, fourth day, right? So it depends on the endoerythrocytic cycle, right? So sweating, dry cough, nausea, vomiting, right? Weaknesses, malaise, these all are symptoms of the malaria. Okay, and characteristic symptom from which you can identify the malaria, right? That definitely is the presence of chills, shivering effect, right? As well as severe body ache. Okay, pain in the back region, pain in the muscles, headache, right? Along with high grade fever and chills. If these are present, then definitely doctor will ask for a laboratory test, and you can say blood smear. If it shows the presence of a characteristic ring stage, right, then it will be identified, it will be confirmed as a presence of, you can say that, malaria. Again, further investigation whether it is falciparum or vivax or oval, that definitely can be done, and therapy on that basis can be started. Fine. So this is list of symptoms. In last lecture, if you remember, we also said that infected RBC, right? This is infected RBC, shows some adhesive molecules on their surface, and that adhesive molecule are responsible for, you can say that, formation of rosettes, right? Rosette means cluster of RBCs, right? Because this infected RBC tend to stick with the non-infected normal RBCs, right? So in that case, definitely clusters will be formed, and these rosettes may clog the microcirculation. That could result in a organ dysfunctioning, like say for example kidney failure, or maybe say for example cerebral arteries that may get clogged, which may result in encephalopathy, right? So such enlargement of liver, right? This all, you can say, could happen in case of, you can say, falciparum malaria, right? So that also you can include as a symptom, right, in some of the, you can say, malaria, right? Say for example falciparum. Okay, so this covers all details related with the symptoms. Now definitely we are going to start with the treatment of malaria, right? As a you can say pharmacist or as a physician, definitely first approach, right, that we should use, that for management of malaria, has to be non-therapeutic, right? So once definitely malaria is there, definitely you have to start with the therapeutics, but prevention is better than cure. So first approach will be in the areas, right, where the malaria is very much prevalent. Then you have to try to reduce the contact between humans and mosquitoes. Okay, that should be the first priority, right? That's what you can say that WHO started maybe 50 years ago, right? That's what was initiated from the WHO, right? They started using, you can say, some of the very simple precautions like wearing proper clothings, you can say stagnant water if it is there, definitely you have to cover with the soil, right? There should not be remnant of the waters, right, nearby the, you can say, living areas, right? And use of insecticidal, residual insecticidal agent. And initially definitely use of insecticidal agents give very good results, but then eventually maybe, say for example, 20 years ago, WHO was knowing came to know that definitely there is an emergence of resistance towards these insecticidal agents also. So that was not that effective, right, which was planned by WHO. But still, some of the very simple precautions, measurements that you can still take, right? So that is proper wearing of uniform, use of some of the mosquito repellents. You must be using some of this at your home also, right? Like say for example permethrin spray, right? You are all using some of the mosquito repellents like All Out or Good Night, right? These all definitely will help in, because that reduced density, or you can say that paralysis in some of the mosquitoes, right, including female anopheles mosquito. So this is effective for all types of mosquito borne disease. Use of bed nets definitely also is a good approach. Bed nets, again simple bed nets as well as these medicated bed nets, right, which are having which are dipped with this permethrin like mosquito repellents. That could also be the case, right? Use of camphor, use of neem, right? This also will help in because they are having mosquito repellent properties, right? So they will also help, right? Additionally, you can have use of some of the innovative approaches like some of the fish, right? They are used to kill the larva of the mosquitoes, right? So that type of fish, right, can be used in large areas, right? In ponds, in rivers, right? That could be also a very effective approach, like. So this is regarding the preventive approaches, right? And definitely now, once the malaria is there, you definitely have to go to therapeutics. And if you remember in last lecture, life because that on the basis of these stages, right, which we observed in the life cycle, asexual life cycle in humans, you can definitely divide the antimalarial drugs in 4 class, right? And that we have just gone through the basics. Now we are going to check the example of this antimalarial drugs. Okay, so drug which are used for acute attack. Okay, if you remember, definitely these drugs which are used for acute attack, these are acting on the endo erythrocytic phase, right? And definitely they are killing the merozoites, right, which are released from the RBCs, right? So these are very good therapy for curing those type of plasmodium where exoerythrocytic stage is absent. Okay, and these are referred as a blood schizonticidial agents, right? So these are best for suppressive or a clinical cure, right? So drug definitely includes quinoline methalones, right? That is the quinine like compound, mefloquine like compound, right? Or maybe say for example 4 aminoquinoline like compounds, that is chloroquine, right? You have some of the compounds which are phenanthrene like compounds, that is halofanthrin, right? Also you have some drugs from the sulfa category, right? So which definitely interferes with the synthesis of folate. Okay, so sulfones, right, or maybe pyrimethamine, right? You know that this individual drugs, sulfones as well as pyrimethamine, individually they are schizonti-static, right? They do not kill the schizont. But if you go for a combination of sulfonamide and a pyrimethamine, definitely it will result in a, you can say that schizonticidal action, right? So combination therapy of sulfones and pyrimethamine. Proguanil also belongs to the same category, right? Similar compounds include your hydroxy naphthoquinone compounds like atovaquone, right? And definitely some of the you can say isolates of, you can say that the Chinese herb, right? That is King Hao Shou, right? That includes artemether, arteflin, artesunate, right? These are some of the examples of the compounds, right, which are derived from this Chinese herbal medicine, right? So these are the drugs which are used to treat the acute attack. Moving towards the second is drugs which affect the radical cure. We have learned that these are tissue schizonticidal agent and they will kill the hypnozoites, right? That is sleeping form, right? In those plasmodium where you can say that the exoerythrocytic cycle is very much important, like Vivax, right? Plasmodium Vivax. So primaquine, tefenoquine, these are 2 examples, right? And these are belonging to the category chemical category 8 aminoquinolines, right? So that's how they are being called as a tissue schizoicidal agent, and they are having effect, that is a radical cure, right, by acting on the parasites in the liver. Fine. So some of these drugs like primaquine, as well as you can say that tefenoquine also, they also destroy gametocytes, right, which will definitely check in the next category. Fine. So yes, these are the drugs which are used to prevent the transmission, right? So that is what I'm speaking, that they are having gameticidal action, and that's how they reduce the spread of infection. But they are hardly used for such type of an purpose, therapeutic purpose alone. Normally they are used for treatment, right? So along with that, they also produces such type of a, you can say, action, that they also prevent the transmission, because they kill the differentiated form of the you can say your schizons that will develop as a microgamete or a macrogamete. Okay, in that case primaquine is the most widely used drug, right, for such purpose. Last category is definitely drugs which are used for chemoprophylaxis. As I told you previously also, that this is causal prophylactic use of these drugs. True prophylaxis is not possible. It is only possible with the vaccination, right? Some of the person who are living in Africa, they have developed natural resistance toward the such type of, you can say, disease. But this type of, you can say, immunity is seen locally only. If a person living in, say for example, Africa, and is having such type of an immunity, is out of country, or maybe is not living in that area for 6 months, right, then that immunity is lost. This is what the research says, right. Fine. So moving again towards the drugs which are used for chemoprophylaxis, they block the link between exoerythrocytic stage and erythrocytic stage, and thus they prevent the development of malarial attacks. So if someone is you can say going to a is going to travel to a country where the prevalence of malaria is there, then definitely they can use such type of drugs, right. And chloroquine is preferred, right, because of the pharmacokinetic as well as the safety profile as compared to the other drugs. Okay, other drugs which are used for chemoprophylaxis, definitely they are mentioned, and you need to remember these drugs also, right. How can you remember each of this class? Because many of the time you have seen that some of the drugs are repeating. Say for example, chloroquine you will find as an example everywhere, except the case of, you can say that for the prevention or transmission. Otherwise you will definitely, or maybe for the radical cure, right, otherwise you will find it in both cases, that is for acute attack also and chemoprophylaxis also. Similarly, if you just check the example of primaquine, right, you will find everywhere except acute attack, right. So how will you be able to remember such, you can say, examples, right, which are been mentioned repeatedly in multiple categories? So for that purpose I have shown here a chart, right. This chart will help you in understanding the life cycle of the malarial parasite, and as well as their pharmacology, and based on this you will also be able to derive therapeutic uses of this drug. Okay, so this chart showing the effect of drug on various developmental stages of malarial parasite, this will help you in understanding all of these details, right. You all know that the stages of malarial parasite life cycle, right, that occurs in the human, they differ definitely in many characters, like say for example morphology, metabolism, and drug sensitivity, right. And definitely that have been shown here, right, that is sporozoite, liver stages like primary, right, that we have shown in a form of, you can say that you can say that the very, you can say, pre-erythrocytic cycle, right. And then definitely exoerythrocytic cycle, at that stage we will call it as a hypnozoites, right, that is a sleeping form, right. So you must be remembering these three phases: pre-erythrocytic, exoerythrocytic, and endoerythrocytic cycle, right. That is what we have learned. Fine. And blood stages includes asexual form, that is schizon and merozytes, right, and gametocytes, right. So the effect of on each of these, you can say, stages, right, for various drugs have been shown, right. You can just see the example of primaquine, right. Here it is having activity against the primary stage of the liver, right, hypnozoites also, and gametocyte, but it is not having action on the, you can say it, blood schizons, right. So that's why it cannot be used for acute attack. Okay, but it can be used for those type of plasmodium where exoerythrocytic cycle is there, right. So to prevent the relapses, definitely for primary, you can say, liver stages it is also effective, and to prevent the transmission, right, that is it is having action on the gametocytes also, right. Now definitely, because no anti-malarial drug kills sporozoites, right. So it is not truly possible to prevent the infection, right? So drug can only prevent development of symptomatic malaria that is caused by the asexual erythrocytic form. This must be very clear to everyone, fine. So because you can just see that there is no drug which is having action on the sporozoid, right? So it is not possible, fine, to have a true prevention, right? That is what we have discussed in case of the chemoprophylaxis also, right? Second thing is, no single anti-malarial drug is effective against all liver and intra-erythrocytic stages of the, you can say, life cycle. That definitely will coexist, right? Because at a time some of these parasites will be in liver, right? Some of them are present in, you can say, the erythrocytic stage. So definitely you don't have a drug, right, which is having action against, you can say, all type of this form. And that's why complete elimination of this parasitic infection, you require more than one drug, and that is the basis of combination therapy for the management of the malaria. Okay, I hope you will you are very clear with this chart, right? And this is the possible way to understand the pharmacology, right, to memorize the pharmacology of all of this, you can say, that anti-malarial drug, right? So now without wasting time, starting with the first you can say that anti-malarial drug, and that is chloroquine, right, which is most frequently being used for, you can say that which is considered a drug of choice, right? If the sensitivity of the parasite is there, that means the area where the malaria is prevalent, the resistance is not developed, is not emerged, right, towards chloroquine, then in that case chloroquine is considered as a best drug. Okay, right? So it is a blood schizonticical agent, right? We have learned that, and it is effective against all, you can say that not four, right? Here you need to make a correction. All 5 Plasmodium species, right? But erythrocytic form of this Plasmodium species, right? Definitely, if sensitivity is there, resistance is not emerged then. Yes, it does not have any effect on sporozoites. That's why true you can say prevention is not possible. This is for all type of, you can say, antimalarial drugs. Similarly, it does not have any effect for hypnozoites. So if Plasmodium vivax is there, is a causative microorganism, right, then in that case definitely you need to give additional combination with some drugs like primaquine or maybe other drugs, right? Or it is also not having any action with the gametocytes, right? Advantages with this drug is it is cheap, it is widely available drug, right? Only thing that is a drawback is emergence, development of or emergence of resistance, right? Otherwise it is a very effective drug and very you can say widely used as an antimalarial drug. Mechanism of action, you need to understand that how it exactly enters in the plasmodium, right? So that is definitely a lysosomotrophic action of chloroquine that you need to remember, that you need to understand. So at the time of diffusion, definitely at neutral pH, it is definitely uncharged. You know that uncharged form of a drug is a lipid soluble, right? And lipid soluble drug definitely can easily diffuse, right? Because like dissolve like, cell membrane is a phospholipid bilayer. So a lipid lipophilic drug will definitely easily diffuse and will enter in the parasite lysosome, right? So it is having preference for this lysosome, right? Once it enters in this lysosome, then it gets converted into a protonated structure, right? So that now it becomes ionized structure, right? Once it becomes ionized, you know that ionized structure is a water, you can say hydrophilic, and definitely hydrophilic structure now cannot come out, right? So the membrane, you can say, definitely now will not allow its permeability. So it is impermeable form of chloroquine that is generated. So that's like called as a trapping, right? And such, you can say, important lysosomotrophic action of chloroquine is selectively responsible for manifold increased concentration within the parasite. Okay, that is needed for the CIDAL action. Okay, so this mechanism is very important. Let's check how it destroys, how it produces killing mechanism inside the malarial parasite. So definitely we have learned that how this parasite gets energy, right? How it takes amino acid from the malarial from the RBCs, right? So definitely endoerythrocytic cycle, that is the major one, right, in the asexual life cycle in the humans. So once inside the RBCs, right, once they get entered in the RBCs through the membrane proteins, this parasite will degrade the hemoglobin, right? And now they will you can acquisite this essential amino acid, right? So through the you can say that degradation of hemoglobin, two things will be produced. One is globin, second is heme. So globin part is used for acquisition of the essential amino acid, and that's how this parasite will grow and will multiply inside the RBCs. Okay. Now, just like we have discussed in the earlier lecture, right? Definitely globin is an important structure, but heme is a toxic substance for that plasmodium species. So there is also generation of a heme that is toxic and soluble, right? And this has to be converted in a non-toxic substance, and that function is acquired by an enzyme present in the plasmodium that is called as a heme polymerase enzyme, right? This all process will happen in case of food vacuole, right? Food vacuole definitely is a metamorphosis that you can consider in the lysosome, fine. So heme polymerase enzyme is the one which converts this toxic heme into a non-toxic hemozoin. Okay, and this is the basis that how a parasite is able to survive within the RBC. Okay? Otherwise, definitely this if heme buildup is there, that itself is a toxic substance for the you can say multiplying structures, right? For the schizons, for the merozoites. Okay, yeah. Remember that this is a non-toxic molecule for plasmodium, but hemozoin is a toxic for our body, right? When high quantity concentration of hemozoin is released in the blood circulation, definitely it could lead to shivering effect, chills, right? It could provoke the release of TNF alpha, right? These all effect could be seen. Now our drug is targeting this enzyme. Which enzyme? Heme polymerase enzyme. Okay, and this is inhibited by your drug chloroquine. Not only chloroquines, many of the drugs like hydroxychloroquine, quinine, right? These are quinidine. These are all drugs, they block same enzyme, they inhibit same enzyme, heme polymerase. So once you inhibit this enzyme, once this capping, right, that is of hemozoin molecule has been done, then definitely now plasmodium will not be able to further polymerize the heme, and this will lead to buildup of concentration of heme, right? And you know that heme is definitely made up of two part, right? If you remember the anatomy, then it is having iron part and non-iron part, right? Non-iron part is called as a porphyrin, right? That is the ring structure present in many structures like hemoglobin, chlorophyll, right? So that's called as a porphyrin, right? So this definitely that's called as an FP. FP is ferrous protoporphyrin, right? Porphyrin is the name of ring structure. Okay, so chloroquine binds to this heme, right, or what you call as an FP, right, and that definitely this complex FP chloroquine complex is highly toxic to the cell and it disturbs the membrane function. Okay, so two mechanism: one, there is buildup of heme, which is itself is a toxic for the plasmodium, right, and second is this complex FP chloroquine complex also disturb the membrane function in case of plasmodium. Additionally, it is also reported that chloroquine can disturb the RNA as well as the DNA activity, right, in the plasmodium. But it is not very sure that whether this is related with the schizonticidal activity or not. Major mechanism is this only, right? Inhibition of heme polymerase enzyme and the consequences which are related with this. Okay, so very important mechanism of action that we have learned for the chloroquine. Resistance definitely is now widespread. Majority of the parts of the world that is in Plasmodium falciparum and Plasmodium vivax, which are the two major first and second number species that are been responsible for the epidemiology of malaria. They are now resistant to chloroquine in the most parts of the world. Okay, and the mechanism of resistance is because of the enhanced efflux. If you remember basic chemotherapy lectures, right, you must have learned efflux, right? There are presence of pumps, right, some special proteins which will continuously move the drug from intracellular fluid towards the extracellular fluids or maybe outside the cell. So this will not result in a effective concentration, right, acidyl concentration that could develop within the plasmodium, right, and this efflux mechanism is definitely because of the enhanced expression of this P glycoprotein, right, which is a multi-drug resistant transporter protein. Fine. So this is you will see as a very important mechanism of resistance in many of the drugs, right. So this definitely you need to remember. So moving toward the pharmacological action, because of its structural similarity with the quinine and quinidine, Similar effects on the heart can be observed. You know that quinidine is an anti-dysarrhythmic agent. It's a class 1A anti-dysarrhythmic agent. So blocks sodium channel, and similar effect for chloroquine also can be seen on a minor level. So depressant effect on the heart could be observed, right? And even with high doses of chloroquine, arrhythmias are also a possibility. That also is because of the similar pharmacological profile like quinidine. Okay. This is a very interesting effect. It is having a mild immunosuppression action, and because of this, you can say pharmacological profile, it is, you can say that nowadays used, or it is been you can say checked for many autoimmune disease, like say for example chikungunya, right? Or maybe say for example other autoimmune diseases like rheumatoid arthritis. It is used as an investigational agent. Fine. So this definitely is an important use that you can correlate with the pharmacological profile. Pharmacokinetics is having a very high volume of distribution. Right now, this definition of volume of distribution and its initial characteristic you have to learn, right? Because a drug, when you know that, right, you know that volume of distribution is giving an idea that what is the quantity of drug present in your blood as compared to the overall distribution in your body, total quantity of the drug present in your body. And that definitely, if you recall, then you will be able to understand that why this chloroquine is having high volume of distribution, right? The reason is definitely it is diffusing at various body part, right, including adipose tissue, right? And definitely if concentration is higher in the body parts as compared to the plasma concentration, then VD will be definitely higher. It is also having affinity for proteins, pigments like melanin, right? That's what you call as a tissue binding. And because of this reason, right, you will also understand that it is involved in a very important, it is producing a very important adverse effect. That adverse effect is called as a retinopathy, right? You know that retina is having a pigmented epithelium, right, to prevent the refraction of light rays, right? Once it enters, light rays enters in your eye, right? Definitely refraction occurs at cornea and lens, and then eventually the light rays falls on the fovea centralis, right? And definitely from there the light should not get refracted, otherwise there will not be a clear vision. And that's why you can understand that there is a presence of a melanin, and that's why the very small part, right, exactly in the middle of your eye, when you appear, right, when you just check your eyeball, that appears always black, right, that small dot, that is because of the presence of melanin. So because chloroquine is having a high affinity for melanin, that is the reason why it will have high distribution in these areas where melanin is present, right, definitely in the retina, and that could result in damage to the retina. That's called as a retinopathy. Fine. So pharmacokinetic will also help to understand the adverse effect profile. We have learned that it's a lysosomotrophic agent in the mechanism of action also, right, and it can be given orally as well as parenterally. Orally definitely you can understand. Parenterally, why I am mentioning specifically is because sometimes it leads to nausea, vomiting. Nausea, vomiting is not as severe as in case of quinine, but still it could be a problem in chloroquine. And in that cases, right, normally you definitely mention nausea, vomiting, diarrhea as an adverse effect for majority of the drug, and NVD, right, that is your favorite adverse effect profile. I know that. But here nausea, vomiting is quite severe, and if such, you can say, severity is there, and understanding the fact that malaria itself is having symptoms of nausea and vomiting, and if you give a drug like quinine or a chloroquine, it could be further problem. So such a case, definitely if falciparum is there, you need to eradicate as fast as possible, right, because the multiplication rate is quite high. So such a case, parenteral route is preferred. Okay, so severe cases or the patients where vomiting is present, then parenteral route of administration is a very important you could say option that you need to consider. Now moving towards the adverse effect profile, definitely fewer adverse effect profile when given as, you can say, a chemoprophylactic agent, right? But when you will go for, because larger doses, then definitely the adverse effect profile could be severe, right? So let's check. Yeah, so let's check the, you can say that larger doses, right, what type of adverse effect have been seen. So largely GI upsets, if when you give by oral route, right, nausea, vomiting are severe, dizziness, blurring of vision, headache, urticaria, right, these are some mild, you can say adverse effect that you can consider. but major side effects, right, that is because of the acute chloroquine toxicity. They are, you can say that, related with the CNS as well as the CVS, right. CVS we have just checked that quinidine like profile, right, pharmacological profile, that could lead to hypotension, vasodilation, suppressing of the myocardial function, right, generation of arrhythmias, right, and eventual, if very high doses have been there, then it could lead to cardiac arrest also, right. As I told you that it is definitely safe in the doses which are given for chemoprophylaxis, but if large doses have been there, right, then and then such fatal effects could be seen. And single dose of 30 milligram per kg, that could be fatal, right, and that shows that safety of margin is quite narrow, right. If you check by parenteral route, then definitely the doses which are larger than 5 gram, right, if given by parenteral route, then also it could lead to fatal symptoms, right. So in that case, definitely this, you can say some of the severe adverse effect could be seen. Retinopathy can be correlated with the fact that chloroquine is having a good affinity with the melanin protein, so tissue binding is responsible for the retinopathy. Also the fact chloroquine is having autotoxic action, right, I have not mentioned here, but chloroquine is also autotoxic, right, so it produces damage to the ear also, right, tinnitus like symptoms, right, that could be observed. And yes, bolus IV injection, as I told you, if been given, then it could result in a severe cardiovascular adverse effect like hypotension, fatal dysarrhythmias, right. Sometime CNS adverse effect like blurring of vision, diplopia, confusion, convulsions, right. This all also can be seen, right. T wave abnormalities in case of cardiovascular, right. Widening of the QRS interval. These all, you can say that effects can be observed, right. So adverse effect profile is quite long, right. But what frequently observed adverse effect have been seen, that I have shown here. Additionally, you can mention along with the retinopathy, you can mention here definitely autotoxicity, right, and you can say that along with this, you can say that severe cardiovascular effect. In case of bolus IV injection, you can definitely add some of the central nervous side effects, right. Therapeutic uses, definitely it is related with the treatment and prevention of malaria, and in some of the autoimmune disorders also, right, we have seen that it is having some immunosuppressant action. So for that purpose, it can be used in rheumatoid arthritis. Actually, hydroxychloroquine, which is just a derivative of chloroquine, that is a very widely used, right, in management of rheumatoid arthritis in many patients, right. It's an effective therapy, right. And similar type of, you can say, observation on the virus also has been observed. So it is used as an investigational antiretroviral drug, right, especially in case of HIV treatment, AIDS, and it is also used many times in some of the viral diseases, right, mosquito borne viral diseases like chikungunya. Okay, so there also it is having a very good antiviral action. So multiple therapeutic uses, right, apart from the malaria, autoimmune disorders, you can say some of the viral disorders, right, that also you can definitely mention as the therapeutic uses, right. Moving toward the second drug, that is quinine, right. Now this medicinal uses of quinine, you can just check the history that it dates back 350 years ago, right. And it was, you can say that it is, you know, that it is a chief alkaloid that is isolated from the cinchona, right. And cinchona definitely is having a history, right, very important history. You can definitely check in the Google, right, a very important historical, you can say that reports, right, how the quinine was isolated, how it was discovered, right, some religious facts also, right, and that all, you can say, it was used widely, right, in the region of, you can say, South America, some of the countries of Europe, right. And eventually we isolated, right, somewhere in the 17th century, early 17th century, right, the, you can say this quinine was isolated, fine. So it is also blood schizonticidial agent. It is effective against the erythrocytic form of all, you can say plasmodium species. Again, you just make a correction, it has to be 5, right. And yeah, if definitely resistance is not produced, right, but resistance is not as prevalent as we have checked in case of chloroquine, fine. Quinine is most of the time it is sensitive because of toxicity profile. Quinine is not a first choice, so most of the case chloroquine is employed first, and if chloroquine resistance is there, then quinine is been taken, right? So definitely quinine is not been reported to show resistance in many part of the world. Okay, still it is not a second choice in case of chloroquine resistance, because now we are having artesunate, artemether, right? Even some of the sulfone and pyrimethamine combination, or doxycycline like compound, they are also, or atoquone, right? These are the drugs which are used as an alternative, and quinine, because of its toxicity profile, is not considered as safe, right? Chalo, so let's check the details. Yes, it does not have any effect on the sporozoites, hypnozoites and gametozoites, just like chloroquine. And mechanism of action is also same like chloroquine, that is inhibition of the heme polymerase enzyme, and thus prevention of formation of hemozoin from the heme. Okay, so same mechanism of action you have to consider. Definitely is now considered as a chemotherapeutic agent in the areas where chloroquine resistance is, you can say, or is been emerged. Okay, so in that case definitely you can consider as a secondary tertiary choice. Pharmacological action just like similar to the chloroquine profile, but additionally we will learn something, right? Say for example depressant action, definitely we have seen that just like quinidine, it also produces depressant action on the heart. Also it produces mild oxytocic effect, right? So that leads to contraction, right, of myometrium, right, in the uterus, right? So that is also a mild effect that can be observed. Also it blocks neuromuscular junction, right? So this is not prominent action just like a D-tubal current, but mild action again on the neuromuscular junction can be observed, right? So such action, right? So that's why it could, see for example, if what you can correlate is, you cannot use this drug in case of pregnancy, right, because it is having an oxytocic effect. Similarly, it cannot be used in some disease like myasthenia gravis because it is neuromuscular junction blocker, right? So such definitely effects you need to consider. It is having a weak antibiotic effect, and that's what I said to you, that the extract, crude extract of the cinchona bug previously was used, anciently was used for the treatment of various type of fever, right? And the fever, if was relating with the symptoms of malaria, magical effects in ancient time was observed, right? So definitely it is because having effects on the malarial parasite, that is primary effect, but also additionally it is having an antibiotic effect, and this definitely also is a beneficial effect that you need to consider, that it will reduce the symptoms like fever, right? Pharmacokinetic profile, it is usually given orally and a 7-day course is been recommended, but here a major problem with the regard to the patient compliance is observed, that is it is very bitter, and because of this bitterness patient compliance is very poor, and also it induces strong vomiting, right, because it irritates the gastric mucosa. In such a case definitely IV infusion, right, in patient who are vomiting, right, or maybe say for example severe infection has been there, then definitely you can go for IV infusion therapy. Okay, metabolized by liver and metabolites are excreted in the urine. Unwanted effect, as I told you, the patient compliance is very poor because it is bitter in nature, right? And because of this bitterness, it also irritates the gastric mucosa. Irritant mechanism, you all know that, and that's why it produces nausea and vomiting, right? If the concentration of quinine in plasma is increased, it is likely to develop a syndrome that's called as a synchronism, right? Now, synchronism is a classical, you could say, disorder, or you could say adverse effect profile, right, which includes all these, you could say, adverse effect, right? So spectrum include nausea, dizziness, tinnitus. If you remember that I've said that chloroquine, and along with the chloroquine, quinine also, right, is autotoxic, right? So tinnitus is a possible action because of the you could say vestibular toxicity, right? You know that internal ear you have 3 parts: vestibule, semicircular canal and cochlea, right? So in autotoxic compound you can again divide into major category: cochleotoxic and vestibular toxic, right? So because of the vestibular toxicity, tinnitus could be produced, headache, blurring of vision, hypotension, cardiac dysarrhythmias, delirium, coma. So you can just see that this profile is very similar to the one which is there in the chloroquine, right? CNS as well as cardiovascular adverse effect along with the nausea, vomiting, right? So that same you can just mention here, but these effects are more frequent and more severe, and this group of, you can say, that adverse effect profile is collectively is referred as a synchronism, which is a classical observation in many of the patients who are receiving the quinine. Okay, additionally because of the bitterness also and because of its inherent property, right, that quinine can stimulate insulin release. This could be a very important you could say effect that you need to consider, right? That is called as a hypoglycemic coma, right? This is because of two reasons. One thing is because glucose is used as a source of energy by the plasmodium species, right? So as such, glucose level will be low in the patient who are having malaria. Secondly, if quinine like drug, right, which are releasing insulin, right, insulinotropic agents, that is how you consider. So release of insulin definitely will further will lead to hypoglycemia, and if hypoglycemia is severe, it could result in a convulsion, it could result in a coma, right? So definitely with insulin, those patients who are receiving insulin, quinine is should not be given, right? That is first thing. And as such also, if insulin, they are not receiving insulin, then also definitely additional IV glucose can be considered, right? If quinine is necessary as a therapeutic, then you need to consider glucose IV as a therapeutic. Definitely patient will respond to that. Black water fever is a characteristic adverse effect, that is because of the acute hemolytic anemia. And this acute hemolytic anemia is typically seen in the patient who are G6PD deficient, right? So that's a first genetic disorder that was been reported. So glucose 6 phosphate deficiency, right? Definitely if is there, then this hemolytic anemia is definitely very severe. Again, consider the fact that malaria itself is a disease which produces hemolysis, right? Because of the rupture of RBC and endoerythrocytic cycle, you know that. So that reason, if hemolysis is already prevalent, and if you give a drug like quinine, then hemolytic anemia will be very severe, okay? And this along with the renal failure could be observed. This could lead to very, you said, detrimental situations, right? So few adverse effect profile definitely you need to remember: synchronism, hypoglycemic coma, and black water fever, right? So this again name is been given because the urine also will be of black color because lots of hemolysis is there. So the excretion, right, that is in the urine also you can observe the black color, right? So definitely resistance is same just like chloroquine, and therapeutic use is also you can consider similar to the chloroquine, fine. But this is not a first choice drug, definitely because of the pharmacokinetic profile and adverse effect profile, okay? So you can consider a secondary or tertiary choice. Similar effect you need to consider for mefloquine and halofanthrin. You just go through the pharmacokinetics and you can say that the adverse effect profile, that's what is little bit of different, right? Otherwise all details are same as that of chloroquine and quinine, okay? So I hope that you have gone through the detailed pharmacology of these drugs. Next lecture we will complete all remaining molecules, right, which are being used as an anti-malarial drug. Thank you very much. If you are having any queries, definitely you can ask through WhatsApp or email. Thank you.